Hello, this is Angie DeRosa, Senior Editor of Contemporary OBGYN. This week we have an interview with Dr. Nanette Santoro, who is chair of the scientific program for the North American Menopause Society's annual virtual meeting. The presentations were recorded and are available starting this week. The theme, Reaching New Heights in Menopause Care, is supported by a rigorous scientific program, including cognition and menopause, novel risk factors for cardiovascular disease in women, hormones of menopause, weight management, and special needs of women when menopause comes early. Take a listen to the highlights from Dr. Santoro and plan to take part in the virtual presentations during this important event. You can find everything online at contemporaryobgyn.net. Thank you.
Well, as the program chair, basically all of them are highlights for me because it's kind of my baby. Yeah. And I got to invite, my most esteemed friends and colleagues and some people that I did not know well, but I had admired. And it's been really a lot of fun. So there's a few areas that I think we have really new content that's important.
Okay.
I think there are new treatments for vasomotor symptoms, so menopausal symptom treatment, and there's new appreciation and understanding of genitourinary syndrome of menopause. So that's something GSM, we've seen getting more research done on it because it's a prevalent problem.
Okay.
And there's a few new treatments out there. So its prevalence and the need to treat it has become, I think, a little more prominent. So they feature pretty heavily in the program. There's also some new treatments, so we have a lot of practical stuff. And we've repeated the Menopause 101 course for people who really want to learn the very basics. So this is kind of introductory. And that really covers, our pre-symposium as well, because we do some treatment there. And I think the cardiovascular disease is important. There's new cognitive information. There's a very important study that will be coming out that's a follow-up to the Chronos Early Estrogen Prevention Study, KEEPS, and that's going to be introduced. We have a session on weight loss that I think is going to be fantastic because, again, I got to invite all these people.
Yes.
A session on the hormones of menopause. Which also includes new information about FSH, the utility of hormones like AMH in measuring in certain circumstances to try to help women understand what their trajectory is to menopause. And we have 3 big new guidelines that have come out this year that are going to be reviewed. I think we have a GSM guideline, an osteoporosis guideline, and an American Heart Association guideline. So those are all very valuable to the members because if you know it, then you can kind of debate it, the fine points. Yes. But if you don't know that field, you can learn what to do.
And even despite COVID, this all has gone forward and the research is still coming out. Like we talk about over here about things that might get ignored. Women's healthcare items that might get ignored under the, because of everything, all the focus on COVID. Do you have any concern for that, or what have you seen?
With women's, well, I think when you have a research slowdown like we do now with COVID,
yes,
you don't see the effects for a little while. It takes about 18 months to 2 years to see the slowdown in research. And we were stopped cold for months. We have 2 clinical trials, one I'm trying to wrap up and one I'm trying to initiate, and a third one that just came through, all of which got delayed because of COVID. So that's really frustrating. It's just going to slow down my publication rate, and everyone is in the same boat. So we'll see. We won't see that immediately. I think we're going to see, everything that's in the pipeline will get done, because if there's one thing that we all had time to do during quarantine, it was to write. So I am getting caught up with manuscripts. And being, confined to quarters a lot of the time, I'm kind of stuck at home. So I'm doing as much writing as I possibly can.
Yeah.
So I think we won't know, we'll see.
the virtual presentations became available, all of them. Is that, as I understand it, as of yesterday?
Yes, so we had a couple of options on how to deliver a virtual program because obviously this is very new. I think we were able to keep 80+% of the original program, which really made me happy. And I think the idea of just offering it when you can is going to be very convenient for people. So we went with that option. We'll see what the uptake is. I think we've done well overall with registration. Good. And, like many other things that have happened over the past season, if you can't all be together, the next best thing is that you can have see it at your own time.
And have you noticed anything with, I guess you wouldn't now at this point, of the viewers, any patterns in the amount of people viewing the presentations?
I haven't seen, actually, because I was off yesterday for Yom Kippur, so I just got back online. Okay. Yeah. So I can't tell you anything about what people are watching or when they're watching it, but I'm looking forward to partaking today.
Yes. And
I do want to go back to one of your questions, because you said, what happens with symptoms during COVID? And I think in terms of patient care, for menopause, it's pretty ideal to do via telehealth. So the adaptation to telehealth has made it actually very, very good for many of my patients, especially new patients, because then we can have the conversation about their symptoms. And, again, it's not the same as in person, but if I don't have to wear a mask and I can actually see someone's face, to me, it's equivalent, because I'm doing both now. I'm doing some telehealth and some in person. And probably the biggest issue for patients is trying to understand when it's necessary to be seen in person as opposed to just having a telehealth visit.
Oh, absolutely. I can attest to that from my own perspective. And I guess too, women being taught to take their menopause symptoms seriously. How have you seen that? Are you seeing women do better with that?
It's hard for me to evaluate that, because patients just come in when they are symptomatic. So I'm only seeing people who automatically, want to be seen. A few patients have delayed treatment.
Okay.
Or, they might have needed a DNC or a surgical procedure, a hysteroscopy, and they didn't want to do it right away. They wanted to wait until they felt safe coming into a hospital. That's probably been the biggest consequence I've seen. And,
okay.
Some screening tests are delayed.
Okay. But you've had a positive experience overall with telehealth.
Oh yeah, telehealth has been amazing.
And what percentage of your patients would you say are using telehealth? Is that?
We have pretty good broadband penetration in the Denver metro area, and that's where a lot of my patients come from. One of the things that Senator Michael Bennet and even Cory Gardner, our two senators from Colorado, he's rural. They want to get broadband to the entire state, because I really worry about the rural parts of the state and more remote areas where people can't get access because the options are terrible. You can have a telephone consult with them, but quite often the billing rules are such that it makes it very difficult, and it actually makes it expensive for those patients. So they're doubly penalized.
Okay. And so let's talk about were there any other studies specifically from the conference that you wanted to touch on that you think might be of particular importance? Or
all my favorites. Well, also I think that we have fantastic keynotes. We have the plenary speakers are great. It was a joy working with Rebecca Thurston. We've worked together for many years, so it's really been fun to support her as president.
Uh-huh.
Noel Barry Mers is an amazing, just scrolling through the program, amazing speaker and investigator. So we were delighted to get her. I think it's really important to see how cardiovascular disease presents in women because it is different. And that's something that's becoming appreciated. Jim Hill was in Colorado for a number of years. He founded the Health and Wellness Center that we have here. And he's a fantastic speaker. He's inspirational, and he will give a very good, in-depth talk on wellness that I think it's impossible not to love. For people who don't know a lot about hormones and how to use them clinically, I think the hormone session is going to be great. There's some new information on how FSH may actually have biological actions apart from just reflecting what estradiol is.
Okay.
And there's some new data saying that anti-Müllerian hormone may be useful for predicting the time to menopause. And Rich Aukas's data looking at mass spectrometry, which is a way to measure very low levels of hormones in women, is also important. I think it will help clinicians understand when are these hormone levels useful and when are they useless, pretty much, because levels are changing so fast you're not going to be able to tell, or you're doing them so frequently you can't tell a meaningful difference.
Uh-huh.
So I think those are going to be helpful. Weight is always a topic that everyone cares about at this meeting because it is one of the most common complaints of perimenopausal women. So we've got some wonderful speakers. Wendy Court has fascinating research on the source of adipose tissue after menopause and that how there's an interaction with hormones and how adipose tissue is laid down. And Dan Bessison is now the medical director of the Health and Wellness Center, the Angie Health and Wellness Center on our campus. And I've heard him speak before, so I was delighted I was able to sweet talk him into giving us a talk on how to manage weight loss and when to use medicines, which medicines work, and when to look at surgery. And, you know, riffing off of weight, we've got the sleep piece because it's always, there's some almost mysterious interrelationship between sleep and weight gain that people are trying to unravel. So that's going to be a great session.
Between sleep and weight gain?
Yeah, so when women their sleep gets disrupted, it's harder to lose weight. Very common complaint among my menopausal patients, but very difficult to get at scientifically.
Okay.
There have been a couple of studies where investigators have sleep deprived people, men and women, and then they kind of let them loose in the cafeteria the next day for breakfast. And the women eat about 500 calories more for breakfast. That's just breakfast the next day after you've kept them up all night. Men actually eat much more in some recent studies. So they have no restraint at all.
That is fascinating.
Yeah, and you know, many of my patients will say, you know, I'm not shocked to hear this.
Yes.
But I'm still not sleeping. Like, how is this going to get better? So for many women, when they're having some sleep disturbances and concurrent with menopause, the best they can do sometimes is just try to hold the line.
The hot flashes are the worst.
Yeah, yeah, they're no picnic.
The night sweats.
And Jen Gunter is our social media speaker.
Yeah.
I just love her editorials. I know she's controversial, and there was a little concern about, you know, her being very controversial. But I think if you're in that realm and you're succeeding, you can't not be controversial.
Yes. So is it separating the health from hype?
Yeah.
Why it matters. Yeah. And that's, I mean, I can't imagine what doctors see now with Dr. Google. That's what my sister and I always laugh. We're always like, we tell each other, don't consult Dr. Google. This is not good.
It can be very frustrating because there are some very smart people who will look it up and get it all wrong, in my opinion. And you know, there's fact, there's legitimate debate, and then there's stuff that's just wild, crazy stuff that's out there, and it's all just, it's like spaghetti on the wall.
Yes.
On the internet. So many people think that they can balance things if they read enough, but that's not true. So there's a lot of opinions out there. I mean, the trolling that goes on with the bioidentical hormone stuff is also incredible. Whenever I, put out an editorial or give some, some evidence on this,
Yes.
I get an irate several emails from somebody who just has the nastiest things to say. I'm in some corporation's pocket. I don't know what I'm talking about. I've obviously never taken care of women, or I'm the most unsympathetic doctor ever. I mean, really negative, nasty stuff, because they're highly committed to this treatment.
Yes.
And I don't understand it.
So I have to tell you as an aside, I actually was going to send you an email about this because Dr. Spong and I got a kick out of this, and Judy, because your article went through peer review, blinded peer review. And so the peer reviewer obviously didn't know who wrote it. And we have a section on our peer review sheet that says, would this article benefit from another expert perspective? And the reviewer wrote in, yes, Nanette Santoro.
That's great. That's hilarious.
Yes. So, but yeah, just, anyway, that was sort of an aside, but I can only imagine with how much money there is to be made in this type of market for women who are trying to get relief from their symptoms, what you're up against as a doctor.
Yeah. It's tough. It's tough. And the other piece of it is that the pharmaceutical, the FDA approved stuff now has become harder and harder to get approved for patients. So the out-of-pocket costs are spiraling up, along with, the general healthcare costs that are going on, and the insurance denials are going up because there's a lot of narrow networks. So if I have a certain kind of patch that works for my patient,
Yes.
can't get it approved. And that actually drives patients to these options if they are less expensive.
Oh, sure.
So it is a little crazy. And then I guess my last, the Udian endowed lecture is another person who we were delighted to be able to attract to Colorado, but she had been at Penn for many years in Yale before that, Neil Epperson. And her work has been on how childhood trauma plays out again in menopause, which is a very striking thing that many clinicians have seen, myself included, in our patients. So that's always a great thing to learn more about, because it's really important in the care of patients to ask those questions and to understand how that's going to change the course of their symptoms.
So are they saying then there's a correlation where the symptoms may worsen in those who had adverse childhood experiences?
Yes. So symptoms in general tend to be worse. And also the childhood experience can kind of come back. So I have had patients, I had one patient who was a nurse who called me with, saying, just having crippling anxiety that came back, and she couldn't believe it. I mean, she just said, I have been through all kinds of treatment for this. I thought this was over. It's not over.
That's fascinating. To think about the role of the biological role.
Condition, some kind of an adverse stress response that Neil is interested in looking at. And I'd be remiss if I didn't, we wrapped up with Judy Regensteiner, if this was going to be a real program, because she's an expert on heart disease and how it plays out in women, and specifically in the instance of women that have diabetes, that they seem to be much more prone. So she's our director of the Center for Women's Health Research at the University of Colorado. Mm-hmm. And she'll riff off of Noel Berry-Merz's talk also about how cardiovascular disease presents, and then she's going to talk more about how it plays out and what the mechanisms are.
Definitely great research, great topics. You've hit, it seems like it's really, the program really has hit all of the key areas, and growing into items like the trauma. we've had a couple articles. We're doing just snippets. I say snippets, but shorter articles to tease the content and link to the program.
Oh, great.
And they're doing really well on Twitter.
Great. That's good to know. Yeah, it was a lot of fun, being program chair, and we have such fantastic staff at NAMS. So Carolyn Devlin, as soon as we knew it was going to be virtual, she just ran with the ball and like within a day, had proposals, and it was pretty clear that this was the way to go. But being able to keep this much of the program in COVID times and just having the pleasure of being able to put your own spin on it, I get to work with the president and with the executive folks in the program committee to just say, how do we do this and a little bit differently?
And this is the first time you all have ever had to do this virtually, isn't it?
Yeah, this is a first, sure. But, there's so many firsts.
Yeah. And so did you want to address more, I don't want to skip over it, but with the social media and menopause separating, from the hype and why it matters, especially in, that follow-up to the piece that you did write for OBGYN, contemporary OBGYN last fall, and the topic of bioidentical hormones, of course. How do practitioners help patients separate fact from fiction?
So there's a few things that people can do. Checking the source of the information and looking for credible sources of information is helpful. So there are ways to do that. There's also ways to look up rumors. So Snopes.com is a great place to go. I tell lots of people, because my sister is very good at doing Dr. Google, is if you're looking up studies, look for the following words. Look for randomized, controlled, blinded. Look for the sample size. If you're looking at studies of menopausal women and, it's a couple of studies of 30 women that have been randomly allocated, that's really not enough to be able to tell you that a treatment is proven to be effective. Look for corroborating data, because not, one single study doesn't always constitute level 1 evidence. So if you see multiple studies that say the same thing with about the same effect size, you're probably onto something. Okay. So those kinds of things are helpful. I tell patients to look for clinical trials that have been registered on clinicaltrials.gov. That requires that they have had some responsibility to report data regardless of what it's favorable or not favorable.
Okay.
So that implies a certain commitment to scientific integrity and quality, because there's lots and lots of these one-off tiny studies that are out there that start, sending patients running for relief that look too good to be true. And, the bottom line is, if it looks too good to be true, probably is too good to be true, is the other thing that I tell a lot of my patients. If you're looking at a hormone treatment that says it's risk-free, that's probably too good to be true, because nothing is risk-free. Other things I tell patients to look for when they're looking at websites are, is the person offering this miracle treatment also in his or her same operation offering you special tests and special formulations? Is all of this proprietary? Because that is potentially an ethical conflict, because they're giving out the same, they have a conflict of interest. They're selling you something. So yeah, they're more likely to diagnose you then. They have money is to be made by doing that. So those things are of concern. And if those aren't disclosed, which was something that really came up in the National Academy of Medicine report, that's really concerning. I've had relatives come to me and say, I went to this doctor, he or she was great, they have all these treatments they're going to do for me, and I just have to pay, $500 for this battery of special tests they're doing in their lab. And then they have these special treatments they're going to give me from the back of the office. And, no, not a good idea.